Nocturnal enuresis, and this is essentially defined as involuntary voiding of urine greater than twice a month at night. And the cause of nocturnal enuresis can involve quite a few risk factors, and some of those include uncompleted toilet training, greater nighttime urine volume, difficulties in arousal from sleep. In addition, family history is actually also associated with nocturnal enuresis. It runs in families. One very important aspect to the etiology of nocturnal enuresis is sometimes there can be organic causes, medical conditions, and the two most common are diabetes and a urinary tract infection. So those two things should be explored during the diagnostic workup. And one final thing I wanted to mention is sometimes problems with anatomy can contribute. So for example, if there's a problem with the ureter or if there's a problem with the bladder sphincter, then that can also contribute. In terms of a diagnostic workup, the very first thing you need to do is obtain a good history from the patient and the parent, of course, because you're talking about children. So ask, is there any pain during urination that can help explore a urinary tract infection? Ask if there's polyuria during the day, urinating a lot during the day, that can help explore diabetes. Another thing that's very important to explore is social history. Is the child under any kind of stress? Are there problems that he or she is undergoing at school or at home? And usually there isn't too much of a diagnostic workup in terms of labs, but some basic tests that you can definitely do are a urine analysis that will help, rule out a UTI, and a basic blood glucose level can help quickly explore the possibility of diabetes. In terms of treatment, the good news is that usually nocturnal enuresis is self-limiting. So the patient and the parent should be counseled about that. But if this is a problem that has not gone away and is becoming very troublesome, then treatment options definitely exist. And those treatment options, most effective one is, interestingly, a bed wetting alarm. And this alarm basically has a mechanism where it triggers whenever the bed becomes wet, and it has a 70% success rate. Now, if this has been tried and still not successful, then definitely medications can be used. And if meds are needed, there's two that are used. The first one is called desmopressin. Now, desmopressin essentially is ADH, antidiuretic hormone. It brings water back. Instead of urinating the water out, the water is brought back into the bloodstream. That's essentially what the mechanism of action of antidiuretic hormone is. The next medication that's used is imipramine. And imipramine is used definitely to treat nocturnal enuresis, but you have to be careful because it has some serious side effects, and one of those side effects is that it can cause cardiac arrhythmias. So now let's take a look at a few vignettes. 5-year-old boy is brought to the office by his mother because of recurrence of bedwetting at night. He has a 3-month-old sister who is healthy. Physical exam is normal. A urine analysis shows specific gravity of 1.01, glucose is negative, protein negative, microscopic shows 0 to 1 WBCs per high-powered field and 0 RBCs per high-powered field. Which of the following is the most important information to share with his parents? Well, of these answer choices, let's take a look. This condition will see if they reprimand him for deliberately wetting the bed. Probably not a good thing to say to a 5-year-old boy. This condition is self-limiting and they should take care to lessen the emotional impact on their child. that's a good option. We'll keep that. This is a potentially serious problem and could represent chronic inflammation of the kidneys. Not necessarily true. This may be a precursor of diabetes. That's not true. And this signifies a serious underlying emotional disorder. Not necessarily as serious. What's probably happened, we don't really know, but perhaps the birth of a sister recently has caused a little bit of stress and he's wetting the bed. So the best choice is B. Next question. An 8-year-old boy is brought to see you because of his parents being concerned about his lifelong history of bedwetting at night. This behavior occurs an average of 5 or 6 times per week. However, he does not have any daytime wetting or incontinence. His parents have tried several tactics to stop his behavior, including fluid restriction, night awakening, and rewards for dry nights, but the behavior has continued. The boy has had no medical problems and is doing well in school and with his friends. His physical exam is normal. Which of the following diagnostic and therapeutic strategies is most reasonable? Well, let's go through these. No further studies in the trial of imipramine. Imipramine can be used, but there's one thing that you should try before you go to meds. IV pyelogram, not really needed. Reassurance that he will grow out of this behavior. This is a good choice, but the problem is that it's going on for so long. Something needs to be done. Lifelong history is obviously very serious, so I'm not going to choose C. UA and the use of moisture-sensitive alarm at night. Yes, this is the best effective treatment for nocturnal enuresis. And UA and trial of imipramine. Again, imipramine can be used if choice D is not successful. And then finally, a 2-year-old boy is brought to the emergency department because of increasing and profound lethargy during the past 4 hours. The past medical history is unremarkable. However, a 7-year-old brother who is a bedwetter has an upper respiratory infection. There have been no other contacts with individuals who are sick. On physical exam, the child's temperature is 99 and he is noted to be hypotensive. There is no history or evidence of trauma. Cardiac monitor demonstrates a ventricular dysrhythmia and the child begins to have a seizure. Which of the following is most likely cause for this child's problem? Okay, well, a little complicated there, but what's probably happened is you have a 7-year-old brother who has a bedwetter. That 7-year-old is on imipramine. And what's probably happened is this 2-year-old boy has ingested that imipramine, and that has resulted in one of the more common side effects of imipramine, which is a cardiac arrhythmia. So the cause for this child, the 2-year-old, having this dysrhythmia, and of course even later the seizure, is imipramine.